Thank you. So I'm Dr. Brooke Ellison, and I'm here to present with my colleague, Dr. Kimberly Noel, on some research that we have been conducting to look at how disability and people with disabilities have been affected in this time of coronavirus. Okay, so as we all know, this current COVID-19 pandemic has really exposed and exacerbated significant disparities that society is facing, significant cleavages that are being brought to light in pretty prominent ways. And the disparities that society faces are in many different domains, but probably none more significant than how people with disabilities have been disproportionately affected by the extremity of the virus and the pandemic itself. So there was data that were published by COVID Tracker as well as the Kaiser Family Foundation that indicated that of the deaths that the United States has incurred as a result of this pandemic, the over 250,000 deaths that we've experienced, 40% of these deaths have taken place in long-term healthcare facilities or nursing home facilities. And that's despite the fact that this population only represents about 1 to 2% of the overall general population. So we're talking about really significant numbers here. So people with disabilities of various kinds have really been disproportionately affected by the burden of the coronavirus and COVID-19. So this is less one specific study and more kind of a cluster of studies that my colleagues and I have been looking at and working on to address the disproportionate ways that people with disabilities have been affected by COVID-19. And this is seen on a spectrum of human rights issues, particularly when it comes to the issues of community participation, healthcare, and technology. But it's one thing to ask that question of how and in what ways are people with disabilities actually affected by COVID-19, and another thing entirely to ask, how could we be proactive and take proactive steps to address these disparities and the disproportionate ways that people with disabilities have been affected, and what remedial and ameliorative measures can we as a society take to address these concerns and to really change our perspective from what is not going right to what we can do better. There's a lot of discussion about building back better, right? That is kind of the call to action. That is the mantra and focus of what we're experiencing right now. And that's kind of the turning of the corner that we all hope to embrace. And when we talk about building back better, we need to do that in a fully inclusive way. And when we talk about inclusion, we need to also talk about people with disabilities. All right, so like I mentioned, this is less one specific study, although I'll talk a bit about the project that has been funded by the OVPR, but more so kind of a cluster of initiatives that all revolve around how people with disabilities are experiencing COVID-19 and where we as researchers and we as just human beings need to better focus our attention. So we're looking at matters of public policy and legislation, doing content analyses, which I'll talk about in a bit, to understand their broader implications when it comes to the lives of people with disabilities, having conversations and one-on-one discussions with people with disabilities themselves to get kind of a phenomenological and experiential understanding of what their lives are like, not just in general, but during this, the real severe and unexpected demands that COVID-19 have placed on people's lives. And then statistical trends when it comes to lives lost, when it comes to additional expenses that people have had to incur as a result of the demands of the pandemic, and the like, and certainly open to other ideas moving down the line as well. And then in addition to that, a series of projects working on technology. Here's the development of technological advances that can reduce the burden that people with disabilities could experience when it comes to living independently, and how we can do that in a much more seamless and fully integrated way. So I'll talk a little bit about some of the projects that we're working on in that space as well. And then as my colleague, Dr. Noel, will talk about briefly remote patient monitoring protocols that allow people to remain in their homes during this quite extreme time. So why is this relevant? Why are we talking about these particular topics? Why is this of interest, not only to me, but to my colleagues as well? Well, we're talking about an application like a remote patient monitoring system. This is a mechanism by which we can keep the most vulnerable people out of the healthcare system to whatever degree we possibly can, while also allowing them to manage the care that they need and remain in contact with their physicians. So keeping people who are most at risk of the most severe cases of COVID-19 out of these settings where they might be most exposed, and keeping them in their homes, which could be the safest location for many of them. My colleague, Dr. Michelle Ballin, who unfortunately wasn't able to join us today, and I have been looking at and taking a real critical look at the New York State ventilator reallocation guidelines, which have guided the thought when it comes to how we allocate scarce resources in the time of a pandemic. These are guidelines that have been drafted several years ago in 2007, with the knowledge that they might potentially have to be used at some time, but with the hope that they would never have to be used. But here we are in the context of a pandemic, respiratory-based pandemic at that, where resources are more scarce than they have ever been, and how people with disabilities, particularly ventilator users, might be negatively impacted by policies that are put into place. And then a project on adaptive technology for those with significant disabilities, to allow for greater independence, allow them to live in the community rather than having to live in some of these settings that are most prone to the spread of the coronavirus. So all of these things have strong clinical relevance when it comes to how people with disabilities can participate in their community, remain in their community, and not be overly burdened by some of the more biopsychosocial aspects of this horrific pandemic. So this is really a true interdisciplinary East-West campus kind of collaboration. So colleagues and I from the College of Engineering and Applied Sciences have worked strongly on various technological advancements. So Drs. Xiaojin B and Dr. Ivy Ramakrishnan from the computer science, as well as Dr. Michael Guzman from electrical engineering, and Dr. Miriam Rafaelovich from the material science, who've all been working on the development of technologies that are amenable to the lives of people with disabilities. And then here on East Campus, working collaboratively with Dr. Michelle Ballin from the School of Social Welfare and Dr. Kimberly Noel from the Renaissance School of Medicine. And the outcome of this work, of all of these projects kind of working together, sitting side by side, is a life for people with disabilities, even the most complex disabilities, like the kind that I myself experience, is a life that can be lived as independently as possible, kind of as fully integrated into the community as possible. So we're working on technology that would allow people to navigate their homes as independently as possible, to interact with their computers and assistive devices of various kinds as independently as possible, to connect with their physicians equally as independently as possible. so that they have the mechanisms available to them to live in their community, to live in amongst their peers and their friends and family. And this is not unachievable by any stretch. It just requires rethinking about things and building back better in an inclusive way. So the projects that that we will talk about just very briefly is a concept called inclusive innovation, which I've been working on with Dr. Kimberly Noel, which we presented at the American Telemedicine Association. The New York State Ventilator Reallocation Guidelines, which Dr. Michelle Ballin and I presented at the Fordham Disability and Social Policy Symposium just last week. And then technology development, which is an ongoing but very active and progressive initiative that I'm working on with researchers at the College of Engineering and Applied Sciences and computer science. So I'm going to pass the baton to my colleague, Dr. Kimberly Noel, to talk a bit about remote patient monitoring.
Thank you, Dr. Ellison. It's an honor to be here. I'll be brief. We had been awarded a little less than $1 million by the Federal Communications Commission to respond to COVID-19 by incorporating new technologies into the health system. And I'm proud to say that we have been able to launch remote patient monitoring for high-risk patients. Although we are launching with heart failure patients, it became absolutely clear to me that there are accessibility challenges, and my work with Dr. Ellison regarding inclusive innovation required a second look of how are we doing this work at Stony Brook for our own patients. And with this, we have launched, what you're seeing here is the remote patient monitoring kit that is sent with a Android device, Bluetooth, blood pressure monitor, pulse oximeter, scale, which is linked to a clinician portal where Stony Brook physicians are monitoring physiologic measures daily for a period of initially 30 days, but can be extended per the needs of the patient. We've done this in several different populations, but where Dr. Ellison's work has been really instrumental is highlighting the access and how we can improve the workflows for those with definitely mobility challenges, as well as thinking outside the box for other disabilities. So this is ongoing work. And right now we're in the kind of clinical realm. Where we've worked most is putting forth the advocacy and preliminary data collection so that we can then further apply for grants in the future. So if anything in this realm is of interest, I'm happy to Brooke and I are happy to collaborate. Lot to say about that.
Okay, thank you, Dr. Noel. So as I mentioned earlier, Dr. Ballin from the School of Social Welfare and I have taken a real kind of critical look at the New York State Ventilator Reallocation Guidelines, which were drafted by the New York State Task Force on Life and the Law, kind of a subcommittee of this overall task force, which deals with complex ethical questions when it comes to matters really of life and death. And they were charged several years ago during the H1N1 and swine flu pandemics to look at how ventilators, which would likely be in short supply in the time of a pandemic, would be allocated during an equally as severe, if not more severe, pandemic, respiratory-based pandemic like the one we're experiencing right now. And there were the New York State Task Force on Life and the Law developed a very kind of progressive and for the most part well thought out policy, which has been at the same time the source of some confusion and the source of some criticism, particularly among people with disabilities who were fearful that there was implicit biases built into the guidelines themselves, which would disadvantage those particularly ventilator users or chronic ventilator users in the time of a pandemic. There was some lack of clarity surrounding the content of these guidelines, which have been addressed on kind of a superficial level a statement kind of implicit or built into the guidelines stating that chronic ventilator users would, in the time of a pandemic, run the risk of having their own ventilator reallocated to someone else should they arrive at an acute care setting, which of course stoked a lot of concern and fear among ventilator users, chronic ventilator users. Since that time, the policy has been clarified to mean only if there were indications of organ failure. So using kind of the SOFA metrics or the sequential organ failure assessment metrics that is often used by ICU and ER doctors to determine whether or not somebody is likely to live in the experiencing a condition like sepsis or some other kind of severe illness. In those, it would only be applied in those contexts, but there are clear recommendations and clear need for greater clarity and kind of adjustments to how the guidelines are currently constructed. And this is not a concern just among Stony Brook University faculty. There has been an initiative or work being done by Disability Rights of New York to try to get these guidelines kind of reconstructed with the added voice of ventilator users themselves. So we put forth a series of recommendations that were discussed at the Fordham Disability and Social Policy Symposium just last week.
Dr. Allison, we have only we're actually out of time, but I want to leave some time for the discussion.
Sure.
In case you wanted to wrap up, just
sure. I'll just very quickly just talk about this is the project that was funded by the OVPR seed grant to work on the technology that allows for an independence and greater access for people with complex disabilities like quadriplegia, like I experience. So a device that allows for computer access using one's tongue, as well as increased eye gaze technology to allow for greater independence and computer access and even telemedicine access. So we're looking for collaborators basically in all fields. This is a multidisciplinary, multifaceted challenge, and we're always looking for collaborators in the diversity of fields that are equally as diverse and broad. We need all minds to help solve some of these problems. And the impact is great, right? We're talking about 61 million people with disabilities in the United States alone. And many of these people, so 5.1% or 3.1 million of these people live in medical institutions that are most at risk of acquiring this condition in the most severe way. And we're working on grants as we speak. We've submitted several grants already, working on an NSF DARE grant, a disability and rehabilitation engineering grant that's in the works coming down the pike. What has been very exciting is that as need has presented itself, ideas have followed, and we're working with just tremendous creativity and excitement and enthusiasm around these issues.